Hello, my friend. I'm so glad to have you here with me today. I am thrilled to introduce you to a friend and colleague, Dr. Cheruba Prabakar in the Bay Area. She is the head and CEO of LaMorinda Gynecology in Lafayette, California. And we know each other from a Doctors Who Have Businesses mastermind. And she's just super smart and doing all these really cool things for women's health. So thanks for being here today.
Thank you so much, Heather, for having me here. Really excited to have this conversation about uterine cancer and really look forward to it.
Great. Well, I'm going to let you tell people a little bit more about yourself, but today we are talking about uterine cancer. It is increasing in incidence. And so I wanted people to get some good information here from an expert on the subject. So please tell everyone a little bit more about yourself first.
Yes, sure. So as Dr. Wad mentioned, I'm Dr. Prabakar. I'm a board-certified OBGYN, and I'm also a fellowship-trained minimally invasive surgeon. And after the first several years of practice, I decided to focus more on gynecology. So right now, I take care of women. My youngest patient is 10, and my oldest is in her late 80s. So the whole lifespan of a woman, and really a huge focus on GYN health, preventative care, abnormal bleeding, endometriosis, pelvic pain, fibroids, all of that, and then menopause and beyond. And our topic of discussion today is just so, timely, given that rates of uterine cancer are increasing in the US. And this is one of the most common things that I'm talking to about patients and screening for all the time. So I'm really excited to be here to talk about this important topic.
Well, thank you so much. So why is uterine cancer increasing? Do we know?
Yeah, I think there are a lot of different, theories, but a couple of main ones. The first is that as a population, we know that, we are becoming more overweight and more obese. And we're seeing this in younger and younger age groups. So before it was mainly about 40, 45, but now we're seeing also the 20 to 30 age group having high rates of obesity in the United States. And obesity is a big risk factor for uterine cancer or endometrial cancer because excess host tissue or fat in the body gets converted to estrogen. And so many women don't know this, but this excess estrogen then acts on your uterine lining and can cause abnormal cells of the uterus or actually just endometrial cancer. And so many people are worried about taking pills and excess hormones and all of that, but we don't realize that our own body fat is actually getting converted to estrogen. And so this is why we're seeing a bigger incidence and higher rate of uterine cancer. And another thing I think that's really interesting is that as a society, we're having fewer and fewer hysterectomies. So when I was in residency, they said, okay, every year there was 600,000 hysterectomies performed. Now it's 400,000. And so in a few more years, it'll probably go down because we have all these other medications and newer, more novel treatments for things like bleeding. And so more women are preserving their uterus instead of getting a hysterectomy. So when I talk to patients, some of my older patients, they're like, oh yeah, I had my uterus out for bleeding when I was 40. But now, because we have all these alternative treatments, less hysterectomies are being performed. And so if you think about that, the more time you have your uterus, the higher your chance also of getting endometrial cancer.
Sure. That is super interesting. I hadn't thought about that. So there is more than one kind of uterine cancer, right?
There are several different types of histologic or pathological types of uterine cancer, but there's two main categories. One that presents in younger women and is more linked to obesity, and then another that presents in older women who are not necessarily obese. And those types of cancers tend to be a little more aggressive, needing, and presenting in later stages. Something that we should also think about is that there are genetic mutations that lead to endometrial cancer. And so sometimes these don't present until 50 or 60. So you may not be obese and you may be doing all the right things, but when you have a gene that predisposes you then you're going to have a higher chance of getting this cancer later on. So knowing the family history and speaking with your gynecologist about this is also very important.
Okay, thanks. So how about deaths from uterine cancer? Are they also increasing?
So compared to I would say, the 80s and 90s, yeah, we are seeing more deaths from uterine cancer. We have about 12,000 deaths now per year from uterine cancer and about 65,000 diagnoses of uterine cancer. So it is the most common GYN cancer currently in the United States. And so, yes, we are seeing more deaths, and we can hypothesize as to why that is. Again, I think when patients bleed right around the 40, 45, in clinical practice, I see it attributed all the time to perimenopause and menopause, which could be, but we still have to actually rule out uterine cancer. In fact, ACOG has now made the age range for a biopsy. It used to be 45, now it's 35. So before, you had abnormal bleeding and they were above 45, you would do a biopsy, and now that number has even come down. So there's a lot of different factors that go into this.
Now, with the two different kinds, is it more one or the other, the older or the younger version that is causing more deaths, or is it kind of both? Do we know?
I'm not sure about the exact percentages, but it's likely the older one, because those are more aggressive. Those don't always have your classic, postmenopausal bleeding symptoms. Sometimes the cancers can be actually picked up on a pap test. When you do the pap test, it'll say, endometrial cells in a postmenopausal woman, which is not normal. And then that can tip you off to doing a biopsy and then diagnosing this cancer. I just had a patient with that. So they don't have all the classic, bleeding symptoms or pelvic pain. So yeah, and they present in later stages and can just be a little more aggressive. And when you talk about older women, they also have other comorbidities, and then survival also goes down because of that.
Oh, sure. So, but when we're saying older, if we're talking about biopsies at 35 plus, that's what we mean by older is 40.
So when I say older, we're talking more like around menopause, like postmenopausal women.
Okay.
So, yep. So the premenopausal, the 40s, 50s, those types of endometrial cancers are usually linked to obesity. And then when we talk about endometrial cancer that presents in 60s, 70s, those are the type 2, or the ones that, are typically can be because of genetic mutations or just spontaneous mutations, but are more aggressive.
Okay. Thank you for making that super clear. Some of our BIPOC community has more deaths, right, than the white community. Can you touch on that, please?
Yeah, I think when we look at the breakdown by race and ethnicity, the non-Hispanic Black population is really suffering from endometrial cancer, and this is a population where the rates have actually increased over years. Now, there may be many reasons why this is, from systemic racism to other comorbidities such as high blood pressure, heart disease, that makes survival more difficult if you were to face endometrial cancer. So it's hard to pinpoint exactly why, but we are seeing this.
Okay. So people should pay attention, especially.
Yes, we should definitely be paying attention to any type of bleeding that's not normal. So, if you're postmenopausal, after a whole year without a period, you're officially in menopause. The average age is 52 in the US. And for some racial ethnic groups, a little bit earlier, maybe 47, 48. But after that, really no one should be having a period. No one should be bleeding. So if you're bleeding at that time, definitely time to seek help and care. Or if you're just bleeding really heavily before that, maybe you're 45 and your periods have suddenly changed and you're just bleeding really heavily, you definitely want to be seeing your gynecologist, getting a good exam, maybe getting a biopsy, maybe getting an ultrasound. So, just doing that workup and having that conversation with your GYN is really important.
Okay. Thanks for saying that. So really, if things are getting weird, we don't just say, oh, it's perimenopause, or I had that whole year off and I have a little bit now, but I'm sure it's fine.
Yes. I see that a lot, actually. Women kind of talking themselves out of, The fact that something could be going on either because of denial or we're just busy, we have a lot of things going on. Oh, I'm sure it's fine. And we just don't quite make it to, I think that's really important because sometimes we can pick things up very quickly that maybe you thought were normal, or we can suggest a biopsy or a pelvic ultrasound. And I can't tell you how many times we've picked up abnormal things and followed up, and it's actually turned out to be a bad situation. So making sure you get those annual GYN exams. It is the annual. So making sure we get a good exam and a discussion with your gynecologist as to what's going on is super important.
That's great. Thank you. And it's oftentimes not something that hurts, so it's easy to try to ignore, right?
Yeah, exactly. I mean, just bleeding can be the only symptom. And a lot of people bleed irregularly. And so it's often kind of just pushed under the rug as, oh, okay, I'm just getting older or I'm reaching perimenopause. It must be that. But it could be something else, in fact. And so we definitely want to look into that.
Okay. So if you have a change in the pattern, you should get it checked out.
Yes. And the good thing is if it's really discovered early, then, surgery may be the only thing you need, especially if it's precancerous cell. But the lower the stage, the better. So
what are treatments? You said that if it's caught early enough, you can just
So before you get to endometrial cancer, there are a few stages of precancerous cells. So if it's truly precancer, where the cells look atypical, they're not quite normal, but it's not cancer, a progesterone IUD might actually do the trick. So that is one of the treatments that we do to help with some of these stages, where we put in a progesterone IUD, it thins the lining, it can reverse some of these abnormalities in these cells. So that's one of the treatments. Many women, though, don't really want to take a chance. They don't want to risk the progression, or if the diagnosis is really just endometrial cancer and it's not precancerous, then we're definitely looking at removing your uterus, your cervix, the fallopian tubes, and the ovaries. So this is a total hysterectomy plus a bilateral salpingo-oophorectomy, which is removing the tubes and the ovary. So that's the complete surgical treatment, plus or minus lymph nodes. So sometimes we do take out some lymph nodes as well, and this procedure is done by a GYN oncologist. These are gynecologists who specialize in cancer treatment and cancer surgeries. So that's done. And then depending on the stage, then we add in chemotherapy, plus or minus also radiation. But when caught early and when the treatment is complete, most patients, have a really good survival rate, a 5-year survival rate. So again, early detection is important.
Nice. So, and someone who has all of their parts removed, I think the cervix, uterus, fallopian tubes, and ovaries removed will have, that's also going to be a surgical menopause, right? So they will have.
Yes. So if they do remove the ovaries for cancer treatment, then yes, that does put you in menopause. And then we have to talk about, what symptoms you have and how we're going to treat that. If a surgery was done when you were already in menopause, when you were 55 or 65, then it doesn't really matter. But if you were 45 or 35 even and had the surgery, then we're definitely looking at some menopausal symptoms. And luckily now we have other treatments, even other than hormones, to help with these. And so there's options out there so that you don't have to suffer. And then for really young patients in their 30s, they may also want to talk about, ovarian preservation, egg freezing, things like that. So if they have not completed their family. Yeah.
And then can these folks with uterine cancer be a candidate for hormones as well as the other medications for menopause?
Yeah. Typically, when you have uterine cancer, you're not a candidate for estrogen therapy anymore, systemic estrogen therapy. But we do have other medications for hot flashes and sweats. So that can really help. We have several antidepressant medications that use for depression that also help with some menopausal symptoms. So we use that. And certainly we can use vaginal estrogen for vaginal symptoms such as painful sex or urinary frequency, urgency, so urinary and vaginal symptoms. So seeing a specialist for that treatment is important.
Obviously, a person would talk about all this stuff with their doctor. an healthcare provider. But our brains all walk down the path, right? Well, what would happen next? What would happen next?
Yeah. It's good to have like the whole picture and the whole, the whole scenario. But even though we can't always prevent these cancers, we can pick them up as early as we can. And so early detection is the key.
Excellent. What are regular healthy things we can do to protect ourselves from uterine cancer?
Yeah, the most important thing I really think comes down to what we eat. And I really believe this for everything in medicine, actually. We have a lot of fancy medications and surgical procedures and all of that. But, the foundation of our health is what we eat. So I recommend a Mediterranean diet, a plant-based if possible, or pescatarian diet, at least 90% of the time, and one that is just full of nutrients, protein. So eating really well is important, and avoiding processed foods and sugars. So it's not just for uterine cancer, but for all the types of cancers that we are facing now, from ovarian or even pancreatic, gallbladder, colon is another one that's also on the rise. So our diet is important, and movement, exercise is critical. So I think diet and exercise is huge. I feel like we always say that, but I really, really do believe that, especially when it comes to cancer. And then really annual exams. There are a lot of women who think, oh, I've already had my kids, I don't need to see a gynecologist. I mean, I can't tell you how many people tell me that when I'm out in the public and they find out what I do. I say I'm a gynecologist. They say, oh, good thing I don't need that anymore. But they're only like, 60. And in their mind, they think, well, I'm done having kids, so I don't need to go. And that could not be farther from the truth, because I really think a lot of the problems start after that. And so really seeing your gynecologist every year, getting a good, thorough pelvic exam, and keeping up with your screenings. So your PAP, especially your PAP, as I said, sometimes it can be a tip-off to uterine cancer, even though the PAP not screening for uterine cancer, it's screening for cervical cancer. But especially in older postmenopausal patients, that can be a tip-off, and we've definitely seen that in practice. And so keeping up with all of those is really, really important. And as I mentioned, obesity is the biggest risk factor. So avoiding that by eating well and moving can help.
Great. Thank you. I do remember when one of my doctors said, well, you don't have to have your next pap smear for 3 years, thinking, okay, I don't need to be examined for 3 years.
Yes. So many people
they're immediately like, oh, good, I don't have to do that. But then, of course, the recommendation is yearly.
Right. It's the pap smear is completely different from an annual exam, which is annually. The other thing, it's really important to know your family history. So not just for uterine cancer, but any other cancers, the pancreatic, is your colon, because some of these genes that I'm talking about encompass these different types of cancers. So maybe you are at very high risk for endometrial cancer, but you present with colon first, right? And then if you have a family history of multiple people with colon and uterine and breast, then we're going to do genetic testing on you. And then if you truly have a gene, then we're going to take out your uterus before you even get the uterine cancer. And so it's important to have that full picture of your family history and communicate this with your physician, because that's what gives me the tip off, like, oh, this patient needs genetic testing. And I have had 2 patients actually with the mutation. Neither of them had endometrial cancer. Neither of them had any cancer, but family history of colon, breast, and other types of cancers. And then we just went ahead and did a hysterectomy before they even got the cancer.
Wow. Thank you for all this. This is really important information for our listeners to know. And because this is on the rise, we do want to pay really close attention. And I love all the interesting things you said about why we're not even really sure why it's, on the rise, because it might just because we have uteruses. Oh, I did have one other question for you. Shoot, I'm going to jump in with this.
Yeah.
And where is that on my notes? I'm looking. Early menstruation and late menopause are risk factors for this, right? Or is that not?
Well, yeah, for a lot of GYN cancers, this is a risk factor because of the number of mutations that can happen when you shed the lining and rebuild the lining over and over again every single month. Similar to ovarian cancer, every time you ovulate, you're bursting the corpus luteum and releasing an egg and then pairing it. And so the more times these cycles happen, the slightly increased risk you're at. In the grand scheme of things, though, I don't think that is a huge risk factor.
Thanks.
Yeah. Yeah. And that's why like having kids is protective. Breastfeeding is protective. So the less number of cycles you can have per lifetime, that actually ends up being protective for a lot of these cancers. So those with more kids, those who breastfed for a long time, because every time you're pregnant, you don't get a period. Many women who breastfeed don't get a period. And so that all ends up being protective.
Okay. So if you didn't have children, you don't need to overly worry, but just get your annual exams like everyone else and eat healthy.
Yep. Yes.
Okay.
Definitely.
Thank you so much for sharing your expertise with us today. I really appreciate you.
It was so much fun.
So please tell people where they can find you and a little bit about your practice too, please.
Yes. So I am located here in the Bay Area in California. So if you are in the Bay Area or you're anywhere in California, I'm licensed anywhere in California, Southern California as well. You can see me as a patient either in person or televisit. But if you're outside California or anywhere in the world and you want some coaching on some of these health topics, you can also get that from me by contacting my office through my website. It's LaMorinda.com. So I'm happy to provide care, either one of those ways. And then you can follow me on social media at the Fibroid Doc. And that's on Instagram, YouTube, TikTok. Yeah.
Nice. And people get to spend a little bit more time with you, right? This is not a 10-minute appointment.
Yes, exactly. So my practice, I like to call it boutique. And so I see no more than about 10 to 11 patients a day. I spend about 45 minutes with all my patients. And so it's a very highly personalized, high access office. And I do offer genetic testing as well and other types of advanced cancer screenings, including the Gallery test, which screens for 50 types of cancers. So yeah, so I do try to be on very forefront of all that is offered in healthcare today and, offered to my patient.
Nice.
Yeah.
And I love following you on Instagram and watching all the cool surgeries you're doing with robots and everything else.
Thank you. And if you just want to be on my mailing list just to see what, we're up to and what the latest and greatest in gynecologic health is, you can do that as well through my website. Just subscribe to my email list and you'll get 2 emails a month.
Well, I'll let everyone know too that the show notes will have your information, so you can just click on that as well. And thank you again for being here.
Yes, thank you so much for having me.